Good day. We're still busy with Mother Baby Friendly Initiative. I'm still Anna Nolte, and we're busy with session 5 and the possible problems that comes from the mother's side and support after discharge. And we're now at lesson 3. Now, lesson 3 on engorged breasts. I think engorged breasts together with painful nipples and the complaint of too little milk are basically the 3 biggest problems that midwives will come across regarding breastfeeding in the postnatal period. So here we go. Now, engorgement and milk stasis is a confusing term that's often applied to any type of breast fullness, include edema, milk stasis, or both. And it's very important that one should distinguish between the two, and because engorgement is a total different problem from milk stasis, and obviously they need to be treated differently. Now, what happens is, first of all, we need to understand the physiological changes that happens immediately after the birth of the baby regarding lactogenesis too, and how milk is being formed. Now, the moment that after the birth of the baby and with the onset of lactogenesis too, there is a marshalling of lymph. In other words, the lymph becomes active. And there's a rapid increase in lactose synthesis, and we have talked about that to a certain extent when we did the physiological changes during breastfeeding. And the lactose, together, this activities of the lymph together with the lactose synthesis cause the onset of copious milk production. So there's suddenly a lot of milk being produced. Now, this process is typically felt by the mothers around 60 hours after birth, and it ranges from about 24 to 102 hours. Now, the same time as this increase in milk production, there's also, to a certain extent, edema, which is an accumulation of abnormal quantities of fluid in the interstitial spaces of the breasts. It might be present already, or it occurs simultaneously with a rapid rise in milk volume. And this edema is engorgement, and obviously the rapid rise in milk volume is milk stasis, and this together form a very large and edematous breast. But two totally different concepts. Okay, let's first of all talk about milk stasis or breast milk retention. This is an uncomfortable breast fullness, and that can occur anytime during lactation. It can happen immediately after birth, as we said on the previous slide, when the milk is coming in, or it can be any other time when excessive milk remains in the breast because the baby is not drinking well or other reasons which we will come to just now, but that causes basically distension of the alveoli and eventually distortion of the individual secretory cells, so that influence the long-term production of breast milk. And we have talked about that when we have done the physiological changes during breastfeeding, when we've said that when we talked about the lactation inhibitor. And this milk stasis is often being caused by ineffective, when the baby is not drinking well, latching is not well, there's not good transport of milk from the breast to the baby, or infrequent removal of the milk. The periods between the breastfeedings are long, and the baby is not really removing milk well from the breast, and that results in overfullness of the breasts. Now, as we've said, different mothers have different storage capacities. Some has bigger and some have smaller storage capacity. So when the breasts have reached their overfull capacity, then obviously we get the distended state. So some mothers might have this distended state sooner or quicker than other mothers, depending on the capacity, as we've said. And the capacity of mothers who are exclusively giving breastfeeding range anything from 18 81 to 606 milliliters per breast. So there's a huge variance in the breast capacity. So it totally depends on the different individuals. Now, if we look further at bulk stasis, what's very important that it's easier to prevent bulk stasis than to correct it later. So, and we have actually talked many times about how it can be prevented, but just again, the best way to prevent bulk stasis and also to solve the problem is early, frequent, and effective breastfeeding by any means. Preferably with a well-positioned baby with a normal effective latch and suck response. And I think that is basically saying it all in these bold letters. That is what is necessary to empty a breast well and to obviously to prevent milk stasis. Now, the causes of milk stasis, I think we have talked about them also several times, but just to revise and summarize them again, it's when the baby is not sucking well, obviously, for some reasons, if the baby is sick or refusing breastfeeding, etc. When they're scheduled as opposed to cue-based feedings, and that makes that the breastfeedings are being scheduled further apart from each other, and the breasts are then accumulating more milk than what the capacity is, and also milk synthesis that exceeds the baby's ability to remove the available milk. And that can be, for example, in the case of premature preterm babies or babies again that's sick, so the milk breasts just produces more milk than what the baby can remove. And then also factors that keep the baby away from the breast, for example, the mother that has gone to work, or the mother can't feed regularly, or aspects like this. Now, regardless of the cause, regardless of any of these things, the result is exactly the same. The milk is retained in the breast and the milk is not being removed on the breast. And as we've said, depending on the storage capacity of the breast, there's a point where the breast capacity is exceeded and the process of involution begins. That means, as we've said, that eventually cause that the secretory cells in the alveoli are becoming, I almost want to say damaged, and that causes that less milk is being formed in the breasts. Now, if we look at the effects of milk stasis, first of all, as we've said, the first component of the milk itself exerts a feedback inhibition on the mammary secretion. In other words, it tells the alveoli is filled with milk, as we've said, and that says to the breast, this lactation inhibitor comes into working to say to the breasts not to form any further milk. So eventually this leads to results in a slower rate of milk synthesis eventually. And that eventually, as we've said, if the milk is not removed, it leads to the physical distension of the alveoli, which further causes disruption of the milk synthesis. And the removal of the retained milk will reverse this process if it begins as soon as possible after the stasis have occurred. Because if it takes a long time after the stasis have occurred, as we've said, we get this damage of the alveoli, and which causes a decrease in the milk synthesis. And the longer it takes before it's been corrected, obviously the more damage will be and the more involution will have happened. And this becomes irreversible as the lactocytes, which are necessary for the milk synthesis, are literally deactivated. And I almost want to say destroyed to a certain extent. Now, the milk stasis can also lead to plugged ducts and inflammatory reactions in the alveoli and in the breast tissue. And this is not infectious mastitis, but it can become infectious and then eventually also become a breast abscess. Now, how do we manage the milk stasis? As we've said, the best way to to manage it, if it has happened already, the best way is to prevent it. But if it has happened already, as I'm saying here, it's a mechanical problem, therefore a mechanical solution is needed. So the main thing is, as we've said, frequent thorough removal of the milk from the breast. That is the most important part. And this can happen by the baby if the baby is able to suck properly, otherwise by hand expression or by pumping. And when milk stasis occurs for more than a few hours for any reason, and especially in the first few days after birth, it's crucial to assure frequent and adequate milk removal. So, and even in the case of hand expression, and we will come to that again, it is very important to remove milk frequently, and obviously all the milk. Now, again, repetition, as we've said, the top priority is removing milk from the breast, which can then be provided to the baby if the baby can't drink it himself. And some women prefer hand expression and think that hand expression is more effective and more comfortable compared with pumping when the breasts are so full, and especially during the first 48 hours after postpartum. And then, as I've said just now, short, frequent expression of the pumping periods is, more effective than long sessions and long and infrequent sessions. Now, empty breasts, and it's very important, may secrete milk very rapidly, up to 58 milliliters per hour per breast. So that is why it is important to repeat the process frequently, especially in the breasts that have a relatively small storage capacity. Now, the second big problem, which is engorgement, and as I've said also previously, that there's often confusion between milk stasis and engorgement, but I hope that when we have done both of these problems separately, that you will understand that they are two total different problems. They can appear simultaneously, but have different causes and they need to be addressed differently or managed differently. Now, engorgement means that the breasts are also over full, partly with milk, but also, and most importantly, partly with increased tissue fluid and blood. Now, during the beginning of breastfeeding, beginning of lactogenesis, as we've said, the lymph becomes very active and there's an increase of blood supply to the breasts in order for the breasts to become active now. And this often causes the edema, and this edema is in the tissue, is tissue fluid that's mostly in the institutional spaces of the breast. But this swelling also obviously cause swelling around the milk ducts, and this interferes obviously therefore with the flow of milk so that it cannot get out easily, and that is why engorgement is often a combination of an overfull but very edematous breast. Now, breast edema is common, but generally, fortunately, very short-lived. It's seldomly more, it's usually 24 hours, more or less, seldomly more than 36 hours, but it's very devastating. The women are really suffering a lot because of this painful breasts. The edema and the tissue surrounding the milk ducts, as I've said, cause that uh, uh, it inhibits the full dilatation of the milk ducts during the milk ejection reflex. So the milk ejection, the mother has a lay down reflex, but the milk can't really flow because of this swelling around the milk ducts. And this caused then the exacerbating milk stasis in the breasts. And here you can see, I think all of you who work with mothers who are breastfeeding have seen really sore and edematous breasts. That's very swollen and very painful, and then the milk does not flow very well. And that's, I think, the biggest distinction between just milk stasis, full breasts, and swollen, I almost want to say, swollen full breasts. And what also happens, often that the nipple is becoming flat because the skin has been so stretched out because of the swelling, and that makes it very difficult for the baby to attach to it and to remove the milk. And the removal of the milk is one of the most important aspects in the treatment, in the management of engorged breasts, as we've seen in the previous stages of milk as well. That we need to remove the milk all the time from the breasts to prevent further problems as well. The mother might be pyrexial. This is usually also temporary, and a temperature is never very high. It's never much higher than 38 degrees, and it should be go away in 24 hours. And this often causes that engorgement is being confused with mastitis. Now, how do we resolve this problem? The first of all is skin-to-skin contact and to infant and allow the infant to self-attach. Now, very important here is not to take the baby off the breast. I know it's a very painful situation for the mother, but what is very important is, as I've said, is to keep to keep on emptying the breast from the milk that is being stayed behind because it can't come out because of the edema. So the baby and the sucking is still the very best management of the situation. So skin to skin contact, because it is such a sore condition, and by applying or using skin to skin contact and to help the baby to self attach, often makes it a very more pleasant and makes that the let down reflex becomes much easier. It also helps, as you've seen on the previous slide with a very swollen condition, the breast is so hard and swollen around the areola and the nipple area that it's very difficult for the baby to get the nipple and the areola into his mouth. And it helps then to use a little bit of hand expression to remove some of the milk, and it can be fed to the baby by a spoon or a open cup, but that also helps to at least just soften the area around the areola so that it helps the baby to get this easier into his mouth. Now, the big focus of our management in engorgement in stasis, in the case of breast milk stasis, our main aim was to remove the milk out of the breasts. In the engorgement, our main aim is also to remove the milk out of the breasts, but to enable us to be able to do that, the edema needs to be relieved. So our main aim is to relieve the edema so that the milk can come out, because the edema, if the edema is severe enough, it prevents the milk from coming out. And we can do that, we can relieve the edema by the application of cold packs for about 20 minutes, followed by off 20 minutes and then on 20 minutes again, on and off, and that helps to reduce the swelling and reduce the blood supply to a certain extent to the breasts, which reduces the edema. It's an inflammatory reaction, and therefore also anti-inflammatory medications will help a little bit, and it will also help a lot with the pain relief. Then there's a lot of also controversy about whether one should apply heat to the swollen breast tissue. I think it becomes overall in the past, for anything that was swollen, whether it was a swollen ankle or whatever, it was usually the principle to use alternatively heat and cold. But now, like this evidence has shown that in the case of swelling, it is better to just apply cold packs to reduce the swelling. Otherwise, with heat, then it brings more blood supply to the affected area, which causes then more edema. So heat should not be used, but as we've said previously, very often, and just with a little hand expression and to get a little bit of milk out, it often helps for the mother to just have a warm shower and we will come to that just now again, or literally just bathe the breasts in warm water to make the flow of the milk easier, and also to help to make the expression, the lay down reflex easier, to help down with a little bit of expression to soften the area around the nipples. Then, and once the milk is flowing freely, so with all this efforts that we've used, the milk removal can be accomplished by any method, by the baby's direct breastfeeding, which is the best method, or the milk can be expressed from the breast if the baby can't feed. And here you can see a summary of the differences between full and engorged breasts. Full breast being hard and heavier and hot, and very important, the milk is flowing. So we have also hard and swollen breasts, but at least the milk is flowing and there's no fever. While here we have the very important, it's very edematous. Here it's heavier and hard because of the milk, it's full, but here it's hard because it's swollen, and it's tight, especially around the nipple, and very important, the milk is not flowing. It may drip, but it's because of the milk that's been in the bigger ducts that's not coming out, that it's very difficult to get the milk to be flowing, and there might be fever for 24 hours. And then the third very swollen, sore breast condition is mastitis, and this in the majority of cases is usually an inflammation of the breast. As the result of milk stasis, the milk infiltrates from the alveoli into the interstitial spaces as well, and that causes the inflammation. So it's not infection, but then later on it might get we might get the formation of a breast abscess, and that might be caused by the mastitis might be caused by infection, or we might get a cracked nipple where the infection goes into the organisms go into the ducts and cause mastitis. So we have two types of mastitis: the infective type of mastitis and a non-infective type of mastitis, which is the non-infective one is the most common one. So here we see that it happens in one or more of the lobes of the breast tissue that gets inflamed because the milk has been forced into the connective tissue of the breast, as we've said, and that makes this wedge-shaped area of redness and swelling. Here you can see a red area here. So it's more localized than in the general milk stasis and the engorgement. Now the woman's pulse and temperature might rise, and she might experience some flu-like symptoms, and including shivering and wriggles, etc. And that's basically because of the inflammatory reaction that's been caused by the milk that's been infiltrated into the connective tissue of the breast. An infective condition can then arise, as I've said, because often one of the milk ducts might be blocked, and then we also get an abscess formation, which then causes the infection. And the infection might also, as we've said, enter the breast via the milk ducts if there's a cracked nipple, for example, and if the main the milk stasis remains unresolved. Now, how do we treat the blocked duct and mastitis? The most important aspect, again, is to improve the drainage of milk, to get the milk to drain, and then obviously when the milk drains, the milk will I almost want to say drain out between the connective tissue, and that will hopefully solve the problem. It's also very important to look for the cause and to correct it. If the cause was milk stasis that has gone over into mastitis, obviously that must be relieved, or if it is infection, that must also then be treated. So the suggested management is frequent feeds, gentle massage towards the nipple to again encourage the milk to flow, because as we've said, we can get blocked ducts, which increase the severity of the condition. Warm and cold compressions. Here, warm compressions are very important because in the case of an inflamed area and in the case of an infected area, we need more blood supply to this area to help with the swelling. And here it's a good way of managing it is by alternating the cold and the warm compressors. And then to start a feed at the unaffected side, and then vary the position of the baby, and then come back to the affected side. And gently massage the breast while the baby is suckling, and show the mother how to massage over the blocked area in order to encourage the milk to flow through these blocked area and to unblock the duct. And then antibiotics in the case of in the case of an infection should be given and anti-inflammatory drugs in the case of a non-infected mastitis, and obviously analgesics because this mothers experience quite a lot of pain, and also rest because they mostly don't feel well. Just a little bit about mastitis in a woman living with HIV. We will come to that in more detail when we do the HIV part, but very important that a mother who's HIV positive, in the case of mastitis or a nipple fissure where there's a crack in the nipple, and specifically when there's bleeding or oozing, that will definitely increase the risk of the HIV infection transmission to the baby. So in these cases, it is being recommended that the baby should be taken off the breast. And while we are normally saying that to increase the frequency and the duration of the feeds, that the baby should suck more often, is definitely not appropriate for these women. And it's, as I'm saying, it's better to take the baby totally off the breast in the case of nipple fissures, but in the case of mastitis, the baby can be fed on the non-affective side, but definitely not on the affected side. The affected side should then be, the milk should then be expressed and been thrown away so that the baby just drink the milk from the non-affected side. So the milk must be expressed and the milk should be, as I'm saying, being thrown away. If only brunt breast is affected, the fetus, the baby can affect it. Sorry, the baby can feed from the unaffected sides, as we've said, for a longer period, so that breast has been stimulated to increase milk production to provide in the needs of the baby. And then when the breast has recovered, the baby can again feed from the recovered breast. And that is then the end of this session. So complete your quiz and then you can continue to the next lesson.